Welcome back to the anatomy series of lectures for PTY103 and SPO104. This week we're going to look at the knee, having moved away from the pelvis and the thigh last week. Next week we'll be looking at the ankle and the foot. Once again we'll be using the fantastic Complete Anatomy by 3D for Medical. You have access to this through your university account, so please follow along if you have it available. Here we are with the view we left you with last week, looking at the anterior knee. If we just quickly move around posteriorly and examine the space here, this is this popliteal space, and it should be noted that the tibial nerve division of the sciatic nerve is clearly visible there. This is an area of special consideration for therapists and something that you should familiarise yourselves with. We're back around at the front of the knee. Above it we've got the thigh, below we have the leg. There's a few layers of muscles already being taken away, but we'll just strip away down to the basics and look at the joint itself. We'll remove the connective tissue to start off with, and now we'll remove the muscular tissue. So you can see that the knee joint is essentially made up of the femur, the tibia. We also have a couple of other joints in the area. We've got the proximal tib-fib joint, and we have the patellofemoral joint, which you can see clearly if I highlight the patella there. If we look at the underneath of the femur, you can see the articular surfaces. I removed the patella as well. We've looked at this in the first week when we looked at the lower limb, but you can actually see just at the anterior or superior aspect of the view we're looking at it, but the anterior aspect, that there's a small dip, which is the groove through which the patella travels. Now the quadriceps group pull on the patella, and it's essential that there's a balance between these muscles to allow smooth tracking. If this gets out of balance, then this can lead to the patella rubbing against the femur in that groove, and it can irritate both the facet joints of the patella and the articular surface of the femur. You can also see that the medial aspect is slightly bigger than the lateral aspect. If I put the tibia back in and we move the image around a little bit, and this time if I just hide the femur, we can see there, and I'll hide the patella as well, you can see there that the medial articular surface of the tibia is actually larger. So this is matching up with the larger articular surface of the femur. The reason for this is that weight bearing mainly occurs on the medial side. We'll just move away the patella again, and so we can see inside the knee joint itself. I'll add in some connective tissue. The first layer of connective tissue that's going in are the menisci or the meniscus. This is the medial meniscus. This is the lateral meniscus. If I was to just isolate it temporarily, you can see that the meniscus itself is effectively deepening the articular surface. So whilst it doesn't have an enormous amount of control over the stability of the joint, it does allow it to sit quite comfortably in its natural resting space. Adding on another layer of connective tissue, and we begin to see that the synovial membrane of the knee is all encompassing. Apart from just outside of it is the posterior cruciate ligament. If I was to remove the synovial membrane, and if we would just zoom in a little bit, you'll see here is the anterior cruciate ligament. So the anterior cruciate ligament is moving from the anterior to the posterior, and the posterior cruciate ligament is moving from the posterior to the anterior. These two ligaments have a key role in stabilising the anterior and posterior translation of the tibia on the femur. So in actual fact, if the anterior cruciate ligament is damaged, there is a propensity for the tibia to slide anteriorly on the femur and increase the wear, and it's likely that early degenerative changes will be seen. Adding in further levels of connective tissue, we begin to see that there's actually a tough fibrous articular capsule as well for the knee joint. Further layers reveal two key ligaments in patellar stability. We've got the lateral patellofemoral ligament and the medial patellofemoral ligament. Quite often when there's trauma to the patella and it's dislocated, one or other or both of these ligaments can be damaged, and it's not uncommon to have them reconstructed. We can add in the fibular collateral ligament, which is on the lateral side. This is a very defined and clear cord-like structure, and if you cross your leg in sort of a figure of four position, if you can imagine that, then this is actually quite palpable as it goes on tension. On the medial side, we've got quite a collection of medial or the tibial collateral ligament and the medial patella and lateral patella retinaculum. These ligaments really blend with the capsule more than stand alone, and quite often if damaged they repair quite well because of the improved blood supply in the area due to the capsule. You can also see that there are several bursa in the area: prepatellar bursa, suprapatellar bursa, and at the very front we've got a subcutaneous infrapatellar bursa and a deep infrapatellar bursa. These make more sense if we begin to add in the connective tissue, and you can see just when we add the quads in how the patellar ligament is situated as it engulfs the patella, and above it we have the tendon of the quadriceps where the quadriceps join. All four quads come in and form a common attachment on the patella of course being a sesamoid bone. So if we strip away the connective tissue and let's just look at some of the muscles, we've mentioned the patellar ligament, which is the attachment point of the quads down on the tibial tuberosity. There is a superior or a proximal attachment point which is on the inferior pole of the patella, quite often the site of tenderness in conditions such as jumper's knee. If we examine the superior aspect of the patella attachments, you can see the common quadriceps tendon, which is a shared tendon between all of the quadriceps muscles. So we'll look at those in a little bit more detail straight away since we're here at the moment. Having zoomed out and repositioned our model, we can see at the front here we have the rectus femoris. Now this muscle was covered last week because it crosses over both the hip and the knee joint. So this is a biarticular muscle. If we examine its action, you can see that it is a knee extensor and it is a hip flexor. Part of the quadriceps group is the vastus medialis, and if we look at the action of this muscle, it is purely a knee extensor. So the vastus group are not biarticular, they anchor themselves on the femur. The vastus medialis and vastus lateralis are anchored on the linea aspera, on the posterior surface of the femur. So they effectively wrap around the femur. Here we can see vastus lateralis, and if I was to remove rectus femoris, we can quite clearly see vastus intermedius. Isolated, you can see that it attaches to the full length of the anterior femur and joins the common quadriceps tendon, and again is purely involved in knee extension. So the front of the knee is relatively straightforward. As we move around to the back of the knee, things get a little bit more complicated. We've got the hamstring group, which again we discussed last week because they're biarticular nature. They're involved in hip extension and knee flexion. If we quickly just look at the actions of, this is biceps femoris, you can see quite clearly there's knee flexion going on. Biceps femoris actually has two heads, and there is a deeper head which only originates on the femur. Medially we have semitendinosus and semimembranosus. Semimembranosus has a broader, flatter, deeper attachment tendon, whereas semitendinosus is much more cord-like and is very easily palpable behind the knee. Gracilis is a knee medial rotator and a hip adductor, as well as being involved in knee flexion. As you can see, the angle of pull is similar to that of semimembranosus and semitendinosus. It's also worth remembering that the hamstring group also involve themselves in knee rotation. When the knee is flexed, medial lateral rotation can be taken care of by the semitendinosus, semimembranosus and the biceps femoris respectively. If we zoom in to the back of the posterior aspect of the knee in a little bit more detail, you can see that there is a long muscle here which is called the plantaris muscle. This actually travels right down to the calcaneus and forms a common attachment along with the soleus and the gastrocnemius. This is actually missing in a specific group of people. We'll hide that away and we'll look at this muscle here, which is the popliteus muscle. The popliteus muscle has a key role to play in the locking and unlocking mechanism of the knee. Because of its angle of attachment, it is actually involved in knee flexion to some degree, but it's quite weak in this area. It's probably better to look at the medial rotation action of the knee. When we go to move and flex our knee through walking, it's important that the popliteus muscle actually unlocks the knee. When we stand in our fully extended knee position, so we're in upright standing, the tibia is locked home on the femur. This enables us to save a little bit of energy in terms of maintaining stability and upright posture. But in order for us to flex the knee comfortably, popliteus needs to unlock that mechanism to allow the hamstrings to take over. I've just added in a more superficial layer of muscles, which we will look at in more detail next week. We've got the lateral and the medial head of the gastrocnemius, and we mention them this week because of their action as they cross over the knee joint. These are biarticular muscles and they form a common attachment down at the calcaneus with soleus and plantaris, and together they form what is commonly known as the Achilles tendon. Finally, if we look at the anterolateral aspect of the knee, we can see that we've got the iliotibial tract inserting at this point. So this is a thick fibrous band, sometimes called the iliotibial band, and it is formed from the long tendon of the tensor fasciae lata muscle, which is located up at the pelvis, and the gluteus maximus muscle. They form a common attachment at Gerdy's tubercle on the tibia, and you can see its close proximity to the lateral femoral condyle. If there's too much tension held in this, then quite often there is some irritation between the tendon and the lateral femoral condyle and a bursa which is tucked away under there, and this condition is known as runner's knee. So that was a brief look at the knee. It's relatively straightforward compared to many joints. It's a synovial hinge joint, but maybe more specifically we might say it's a modified hinge because of the additional rotational aspect available at the knee. Its main anatomical movement or physiological movement is flexion and extension, and we're only able to achieve rotation through a natural walking gait, or if you are in an open kinetic chain with the feet off the ground, the hamstrings can rotate the knee. Next week we're going to move on to the ankle and the foot, and we'll pick up some of the muscles again from the back of the knee, but then concentrate on those that operate in the ankle area. Thanks for listening, and we'll see you again in the lab.